The next patient is Mr. Jones. Mr. Jones is a 79-year-old male who presented today complaining of dyspnea for the past 12 months. Initially, the dyspnea was only present on exertion, however, it is now persistent at rest. Along with the dyspnea, he also reports a productive cough. While the cough is persistent all day, he reports that it is the most intense in the morning and is accompanied with mucoid sputum. He states that he is coughing up approximately 2 tablespoons of sputum per day. He is only able to walk about 10 steps before needing to rest. He reports that resting does assist with the dyspnea, but it does not make it go away completely. He reports no GI symptoms or abdominal pain and has not experienced any chest pain or tightness. Mr. Jones is a retired factory worker who lives with his adult son. His wife passed away 18 months ago due to ovarian cancer. Mr. Jones has 3 adult sons. His eldest son suffered an MI, and his youngest has type 2 diabetes. Mr. Jones has 8 grandchildren, all of whom are well. He had one sister who passed away last year due to an MI at the age of 72. His father passed away at the age of 60 due to lung cancer, and his mother passed at the age of 70 due to a stroke. Mr. Jones was diagnosed with hypertension and dyslipidemia 15 years ago. He is currently taking losartan 50 milligrams daily and atorvastatin 40 milligrams daily. He reports no adverse reactions to these medications and states that he is compliant with taking them as prescribed. His drug coverage is through Ontario Drug Benefit. He does not take any vitamins, supplements, or samples. He drinks 1 to 2 beers a few times a year on special occasions, and he has never used any illicit drugs. Mr. Jones is a former smoker with a 58-pack year history. He quit 2 years ago at the time of his wife's cancer diagnosis. He received the flu shot last fall and the pneumococcal vaccine at the age of 66, with the second dose being given 1 year later. He is also known to have BPH and a remote left wrist fracture due to a bicycle accident many years ago. He is allergic to tomatoes and oranges, which cause a rash to develop. He has never had surgery, and his weight has been stable for many years. Mr. Jones was born in Canada and has not traveled since 2008, when he went to a resort in Mexico. His only other travel history is to Myrtle Beach for his honeymoon in 1961. Mr. Jones reports that his dyspnea is interfering with his daily activities, such as meal preparation, laundry, and spending time with his family. Prior to 1 year ago, he was able to assist with light housework, but is no longer able to carry out these tasks as he finds them to be too demanding. Prior to last year, Mr. Jones reports little physical activity other than daily evening walks with the family dog. He is no longer able to do this due to his increasing dyspnea. He tries to follow a low-sodium diet, but sometimes struggles to do this as his son is now doing most of the cooking. Having watched his wife and father suffer through cancer, Mr. Jones is very concerned that he may have lung cancer. He recalls that his father was frequently coughing and short of breath at the time of his diagnosis. He is struggling to cope with the loss of his wife and relies heavily on his son for assistance. He wishes to regain some of his independence and become more involved with his family again. Today, Mr. Jones's vital signs were as follows: temperature 36.6 degrees Celsius, heart rate 70 beats per minute, regular rhythm. Respirations were 25 and shallow. Blood pressure 135/85 with a 12 millimeter pulsus paradoxus. Oxygen saturation was 91% on room air. He is 180 centimeters tall and weighs 59.2 kilograms. As such, his BMI is 18.3, which classifies him as underweight. I did complete a physical exam on Mr. Jones, and I'll summarize the results for you. Generally, Mr. Jones is alert and oriented ×3. He is cooperative with answering questions, although he frequently pauses in his response in order to catch his breath, and his respirations are audible from approximately 1 meter away. He appears to be in mild respiratory distress. Seated on the exam table, he is noted to be breathing through pursed lips and leaning forward. Accessory muscle recruitment is observed with ventilation. Examination of his head, eyes, ears, nose, and throat revealed that Mr. Jones is normocephalic and there is no evidence of trauma. His pupils are equal and reactive to light. There is no erythema or exudate present in the pharynx. There is no conjunctival pallor or scleral icterus. His tympanic membranes are clear and no nasal polyps are present. Examining his neck revealed that the thyroid is non-palpable and the trachea is midline. The JVP is not elevated and no lymphadenopathy is present. Upon examination of the chest, it's noted that there is increased anterior-posterior dimension. There are no masses, scars, or lesions present, and there is no kyphosis or scoliosis. Percussion revealed hyperresonance bilaterally, but there is no tactile fremitus. Diaphragmatic excursion is equal, 3 centimeters bilaterally. Auscultation revealed decreased breath sounds and adventitious wheezes bilaterally at the lung base. There is no egophony and no whispered pectoriloquy. However, Hoover's sign is positive. I then auscultated his heart. S1 and S2 are present, although distant. No murmurs are heard, and there are no heaves or thrills. Examination of the abdomen revealed no masses, scars, or lesions. Normal bowel sounds were present, and the abdomen was soft. Upon palpation, no splenic or hepatic enlargement is noted. The liver span is 9 centimeters on percussion. A DRE was performed, and mild enlargement of the prostate is present. This is consistent with his known BPH. I then examined his his extremities. Peripheral pulses were present bilaterally. There's no edema or erythema present. No varicose veins, ulcers, or calf tenderness was noted, and Homan's sign was negative. Mr. Jones's nail beds are heavily stained a yellow-brown color, but no clubbing or cyanosis is present. Taking all this into consideration, I have come up with 4 differential diagnoses for Mr. Jones. Given the prolonged onset, lack of fever, I did rule out acute infectious diseases such as pneumonia. The first and most likely diagnosis is COPD. Given his current clinical presentation, coupled with his significant smoking history, I believe that this is the most probable diagnosis. COPD frequently presents as progressive dyspnea and a productive cough. This diagnosis is strengthened by findings including a low oxygen saturation, tachypnea, the presence of pulsus paradoxus, Hoover's sign, accessory muscle breathing, low BMI, decreased lung and heart sounds, wheezes, positional adjustments to relieve dyspnea, and Mr. Jones was a factory worker, which may have exposed him to airborne irritants. Pertinent negatives include the absence of edema, absence of fever, nausea, vomiting, hematemesis, and there's no indication of a DVT. A second diagnosis, unfortunately, is lung cancer. Given his significant smoking history, Mr. Jones certainly has an increased risk for this diagnosis. His productive cough and dyspnea also suggest this must not misdiagnosis. Lung cancer may also explain the tachypnea and low oxygen saturation that were observed during the physical exam. However, Mr. Jones does not present with hemoptysis, chest pain, or hoarseness. Unfortunately, lung cancer presentation is vague and it's variable from patient to patient. So at this time, this diagnosis cannot be excluded and does require further investigation. Thirdly, Mr. Jones's productive cough and dyspnea may also be caused by bronchiectasis. Patients with bronchiectasis typically present with a cough and the production of large amounts of mucoid sputum over a prolonged period of time. However, Mr. Jones does not present with hemoptysis, wheezing, fever, nasal polyps, weakness, fatigue, weight loss, or crackles upon auscultation. The precipitating factor for bronchiectasis is also widely variable. It typically presents after an infection or in immunocompromised individuals, but this is not applicable to Mr. Jones. However, up to 50% of cases are idiopathic, and others may be related to inhaled irritants. Again, Mr. Jones's work as a factory worker may have exposed him to this irritant. My final differential for Mr. Jones is congestive heart failure. CHF does present with wheezing and dyspnea, and Mr. Jones does have dyslipidemia and hypertension, which increase his risk for cardiovascular disease and the development of CHF. CHF may also explain the tachypnea and the low oxygen saturation. However, there are numerous factors that make this diagnosis less likely than the previous three. Patients with CHF are typically found to have edema, an elevated JVP, tachycardia, diaphoresis, peripheral cyanosis, cold extremities, pallor, and an S3 gallop, none of which are observed in Mr. Jones today. Clearly, Mr. Jones is going to have to go for some further diagnostic testing, and hopefully we can narrow down what's happening to him. Thanks.